Oi, boa tarde. Bem-vindas e bem-vindos ao primeiro colóquio, né, desse semestre. Só para avisar vocês, os próximos desse semestre já estão anunciados, estão na página, né? O próximo vai ser de gente nova no IME, tá? Já tem o Fábio Butler, da Computação, e o Renato, da Pura. Tá? Então, para anunciar os próximos. Agora, para anunciar o nosso convidado de hoje, eu vou chamar a professora Lúcia, tá? Que vai apresentar.
Obrigada, Débora. Boa tarde. Bom, hoje nós temos a honra de receber o professor Sam Clark. Ele é professor do Departamento de Sociologia da Ohio State University, mas é afiliado também a outros projetos e a outras universidades, como a Universidade de Witwatersrand e a Universidade de Washington. Ele é demógrafo, epidemiologista, cientista de dados, trabalhou em projetos para estimar a prevalência do coronavírus e o excesso de mortes por Covid-19. Em especial, trabalha para o melhoramento da autópsia verbal para determinar causa de morte, com modelos matemáticos de mortalidade humana, com estimativas indiretas de mortalidade infantil e com estimativas de mortalidade em pequenas áreas. O professor Sam Clark lidera o grupo de desenvolvimento do OpenVA, que é um software para determinação de causa de morte. É membro do grupo de referência da autópsia verbal da Organização Mundial da Saúde. No Brasil, ele faz parte do grupo de validação da autópsia verbal, que é um projeto FAPESP, que é coordenado pelo professor Luiz Fernando Ferraz, da Faculdade de Medicina, e do qual também fazemos parte eu, a Carmen, o Paulo, a Clarissa e outros, claro. Sam, thank you. It's an honor and a pleasure to have you with us.
Great, thank you very much. So I will start here. It's here, right? Okay, great. I want to start by thanking all of you for inviting and having me here today, and also apologize that I'm going to speak in English because I cannot speak Portuguese like this. So thank you for bearing with me on that. So today I'm going to talk about InSilicoVA, an algorithm that our team has put together to facilitate the attribution of cause of death using data from the verbal autopsy algorithm. So the talk will have a little bit of preliminary material. I'll talk a little bit about the motivation for this project as a whole, and then spend most of the time talking about the algorithm itself and a little bit about some of the plans that we are making to do things now, which as was just said, involves the Department of Pathology here at USP. So I want to acknowledge the many colleagues and collaborators that we have on this project first. We work closely with a group called the Alpha Network of Health and Demographic Surveillance System sites in Africa, 10 of them, that have provided most of the data that we used to develop this algorithm. Specifically this Karonga site in Malawi and one in South Africa called Agincourt. We also work with the South African Medical Research Council, which is a government organization under which cause-specific mortality and mortality reporting is done in South Africa. And our supporters are the Bill and Melinda Gates Foundation, the National Institute for Child Health and Human Development in the United States, and the Bloomberg Data for Health Initiative, which supports this work. So, as my introduction said, I'm not a statistician. But I have two colleagues here who I want to acknowledge in particular. They're both statisticians and work closely with us on this. Richard Lee is at the University of Santa Cruz, University of California, Santa Cruz, and Tyler McCormick is at the University of Washington. And together with me, we developed the work that I'm talking about today. So I'll turn now to why we feel like this work is important and what we're going to be doing. And as I do this, I'm going to forewarn you that this talk is essentially an application of statistical methods, and I'm going to pay more attention to the bigger framework than probably most of the talks in this series do. So here's a graphic that was prepared by my colleagues and myself in 2016, summarizing the cause of death information available globally by country. And it has a very simple scale here from low to medium to high. I won't get into what those actually mean. But essentially, I want you to get the picture that globally, if we look at the Americas, we're doing okay, except for Bolivia. Brazil is in the middle of this metric. If we look at Asia, there's a mixture of things. These countries with the red dots have sample surveillance systems, so they don't cover the entire population with a mortality reporting system, but they do have a sampled system that produces interesting results. Of course, Australia and New Zealand are okay. If we look at Africa, there's a big hole, essentially, globally. For most of the deaths in Africa, they don't get recorded, and if they don't get recorded, they don't get a cause. So that's a very big challenge. So the metric that we are aiming to produce with this method is something called the burden of disease. And it's a very simple thing. It's the distribution of deaths by cause, so that we can identify which are the causes that are most important in a given population, and then we can have public health interventions that address those causes. We can prioritize, and we can monitor to see what's happening after we do an intervention of some sort. So the basic idea here is very little information for Africa, which is also the area which probably needs these things the most, and certain parts of Latin America and Asia also using methods like this. So just to review what we're doing cause of death determination. Essentially, to do this, we need to register deaths and provide them with a cause, calculate this burden of disease, and keep track of things. In these resource-constrained settings where we work, the traditional methods for cause of death determination do not function because they're not feasible. Doing autopsies, medical record review, and so on is an expensive enterprise. The first world countries spend billions of dollars doing this. Countries like Brazil also spend a lot of money doing this. Everyone who works in the autopsy service at the hospital knows how complicated and expensive it is. So places that are very poor, in many of those settings in Africa, this is totally impossible. So that's why we are focusing on this verbal autopsy method. It's a very difficult and strange method, but it's the only thing that we can do in those kinds of places. So we'll turn immediately to talking about that. So the overall aim of verbal autopsy is to assign a cause to a death with the data and essentially classify that death into an abbreviated cause list. There's an international classification system which contains about 11,000 very specific causes. The verbal autopsy is only going to use 65. So we're classifying into a highly abbreviated list compared to the one which is used in better systems. The data are two types. The first category of data comes from the verbal autopsy interview, and this is done with a knowledgeable caregiver or someone who is observing the person who dies and can answer questions about the signs and symptoms and the history of that illness or condition just before the person died. So this is the main death-specific data. Then we have a second category of data, which we call, Tyler and Richard and I named this, symptom cause information. And this describes the relationships between the verbal autopsy signs and symptoms, what we collect from the respondent, and the categories that we want to classify the death into. So the relationships between the causes and the symptoms. This set of data, of course, is the same for all of the deaths and comes from an independent source. So there's two ways of doing the classification. We can have a physician read the verbal autopsy and produce their best guess as to what was the cause, or we can use an automated statistical mathematical algorithm that also looks at all of those data, combines it with the symptom cause information, and classifies the death in an automated way. So here is a quick summary of the kind of advantages and disadvantages of this approach. So the biggest advantage is that it's feasible, and it can be done in almost any setting. It's comparatively cheap, it's comparatively tractable. The logistics, the skills, etc. necessary to do this are minimal, so you can roll it out in places with very little infrastructure. And if you use the computer coding, we don't require huge advanced skills. We don't have to have physicians with full medical training. It produces reproducible cause assignments in a timely fashion. We run the algorithm, we can run it again, we get the same results. And we don't take the time of physicians away from other activities like actually seeing living people. And it is capable of providing useful cause of death and burden of disease information for public health assessment and planning. So it is actually useful. The disadvantages are also very severe. It's much less accurate compared to the traditional cause of death determination methods, autopsy, medical review, etc. The abbreviated cause list doesn't easily mesh with the full ICD system. So if you want to use these information together with other information in a system, you have to basically build a model to figure out how to combine them together. And it's something we're still working on. And the whole thing is inherently low information with many potential sources for bias and error. So the classification is difficult because of the low information, but also all of the potential biases that creep in. So why do I work on it? Most of my colleagues have refused because this method is difficult and produces results that are sometimes difficult to deal with. Because I didn't mention when I was introduced, is that I'm from Kenya, so I'm African myself, and I have structured my career so that I mostly work on issues, health and population issues that affect Africa. So for me, it's just an interesting thing to do that is useful in the place where I come from. So the results are still useful at a population level. This computer-coded VA is the only feasible solution for large-scale systems. So at the moment, we are beginning to work with national governments in African countries to do this on a very large scale. And it's impossible to use the physician approach when you do that. So the computer-coded approach is the only solution. So what I'm going to do in the remainder of the talk is talk specifically about the algorithm. We will show some equations and then talk a little bit about results. And that's that. So straight into algorithms. The VA cause coding algorithms, there's essentially 2 camps and about 6 or 7 algorithms that have been used in the past. And they all have these 3 components. The first one is the data themselves coming from the verbal autopsy interviews. The second one is the symptom cause information coming from an independent source that relates the symptoms to the causes. And of course, the third one is the logic itself, which combines those 2 sources of information and produces the classification. So the reason I've enumerated this is because most of the literature on these things does not enumerate those 3 components. And a lot of work has been done comparing the performance of algorithms, and they essentially conflate these 2, the SCI and the algorithm logic. So they do comparisons where they change both the logic and the SCI, and then they say, this logic is better than that logic. But if you change the SCI at the same time, you can't really make those statements. So there I just underline that. Performance depends on both the logic and the SCI, and of course, the data that come in. You can swap out the SCI for a given algorithm, and you can change its performance significantly, which is a plus and a minus. It does mean that the performance of an algorithm can evolve with the underlying epidemiology of a population if you continually adjust these SCI so that they take account of changes in that relationship between the symptom and the causes. So we're going to focus on the algorithm logic right now and talk about the SCI a little bit at the end. So I'm going to kind of set the context for InSilicoVA by first talking about its predecessor algorithm, which is called InterVA. So InSilico essentially grows from this earlier algorithm. InterVA stands for Interpret VA. It was developed by a public health scientist named Peter Bias and his colleagues over about 2 decades. And there are many, many publications. All of these ones were ones that I could find easily a few years ago, probably 300 or 400 publications both developing and using this algorithm. The latest version of this is InterVA 5, and unfortunately, Peter Bias passed away during the COVID-19 pandemic. So although we don't use his algorithm ourselves, we got stuck maintaining the InterVA 5 code. So now we produce the software that other people use for this algorithm. So InterVA is a computational algorithm that was designed to distribute a single death across all of the 65 causes in the VA cause list. And then, most importantly, to generate a population-level distribution of causes for the group of deaths in a given VA population. So I'm going to just briefly describe the guts of it, which is very simple, and then show why we thought we needed to do something to improve this. So a little bit of notation, which we're probably going to forget immediately, but I'll do it anyway. We have J deaths, Yj. We have N causes of death, Cn. We have a death Yj with cause Cn, that's Yjn. We're going to have K signs and symptoms, and they're binary valued, so those are going to be Sk. Basically, that's saying you have the symptom or you don't have the symptom. That's it. And of course, each death gets a vector of signs and symptoms, capital Sj. And then we have cause-specific mortality fractions, Fn. Those are the burden of disease values. So the data that come in for each death Yj is this vector of symptoms with elements Sj through K. Those are the data from the interview saying, I had a cough, I didn't have diarrhea, I was diagnosed with HIV, etc. Then independently, we have the symptom cause information, and I may refer to it as prob base for probability base. This is Peter Bias's notation for this, and it's well known by this name, even though really it's just this matrix. So the values here are the conditional probability of a symptom given a cause. And these conditional probabilities can be elicited from physicians. We can have a meeting and have a group of physicians in a room, and we can say, if cause 1 is HIV and S1 is fever, what's the probability of a fever if you died from HIV? And then if we move down to another symptom, it could be diarrhea for HIV. Again, we get a number. So those are regular conditional probabilities, 1 for each combination of symptom and cause. So then, of course, we can use Bayes' rule, and we can write down the probability of a given death and dying from a given cause and a particular set of symptoms for that death. And then, of course, we can arrive here at the probability of a death from a given cause, given their set of signs and symptoms. This is going to be the probability of that symptom vector given the cause times the probability of that cause in general times the over the probability of that symptom vector in general. Now, if we assume that the signs and symptoms are independent given a cause, the probability of a specific sign and symptom vector is the product of the applicable prob-based values, those conditional probabilities, when the sign and symptom exists, and their complements when it doesn't. So we can expand our expression here for the probability of the cause given the specific sign and symptom vector. Here we have that product. Here we have the SCI values when a symptom exists, when it doesn't, and we have the probability of that sign and symptom vector in total underneath. So if we look at this, we have the signs and symptoms here, and we have a component in this expression for when the symptom exists and when it doesn't exist. And that's not what InterVA does. So this would be nice and simple Bayes' rule. What happens with InterVA is that the factors that have to do with the absence of a sign or symptom are removed from that expression. And a new quantity is calculated that just ignores the absence of a symptom. And I'm calling this thing a propensity. And I've got a little prime here saying that we are calculating something a little bit different. We're calculating the probability of that death resulting from a given cause conditional on the subset of symptoms that exist not the ones that don't exist. So the problem with this S prime is that it's different for each death. So we're actually going to calculate a slightly different quantity for each death. Yes, I think that's essentially what I said already. This is, we think, relatively important. The proper Bayes definition of this quantity is not equal to what is actually being calculated by InterVA. And so we think that what happened here is that Peter Bias was trying to calculate the correct quantity, and the data that he had available only had the presence of symptoms and had thrown away the absence of symptoms. So he just threw out that part of the definition and decided to go with it anyway. So we renamed that conditional on S prime quantity a propensity. And what InterVA does is report the top 3 largest propensities that exceed a value of 0.4. There's no justification for this 0.4. If a death doesn't have any propensities that reach that threshold, it's labeled indeterminate. So between 5 and 20% of the deaths in every data set receive this indeterminate cause based on a threshold for which no justification exists. So you can, of course, move it to 0.5, move it to 0.3, and you radically change the number of deaths that get this indeterminate cause. The cause-specific mortality fractions, that little f, are simply arrived at by summing up the propensities for each cause across all of the deaths in the data set. So it's just a direct transformation of these individual values. So that's InterVA 5. So implications here, it doesn't actually compute the quantity that we want, and this is not a probabilistic algorithm because of essentially breaking Bayes' rule like that. It computes a probable cause only using symptoms that were present and their corresponding propensities. Critically, this is a fundamentally different quantity for each death, which makes it theoretically difficult to compare across the deaths in a population. Doesn't differentiate between observed symptoms and missing data. So there's a problem that arises in most data sets where you essentially have 3 options. You have a symptom exists, a symptom definitely doesn't exist, or the data are missing. A lot of times people conflate those last 2. InterVA, of course, throws all that away because it only pays attention to the presence of a symptom. It's pretty sensitive to noise in the data and obscures data-related problems that have to do with missing symptoms. CSMFs are a deterministic rescaling of the individual level cause determination, and it has many other problems involved with the software that we identified that I won't talk about here. So the bottom line, after we investigated InterVA 5 and figured out what it was doing, was that we needed a lot of improvements. So we decided we would talk about developing a new algorithm, InSilicoVA. We named it InSilico for on-chip computational VA. So this is a statistical computational algorithm, and our aims here are to do 2 things. At the individual level, produce a distribution of probabilities for each cause, and at the population level, a distribution of counts of death for each cause, and ensure that those 2 things are consistent with each other. So that if we have uncertainty here, it's reflected properly in the population level quantities. So of course we want to link them and make them consistent. We thought that having quantification of uncertainty at both levels is very important. And we wanted to utilize all of the information from all of the deaths, including missing symptoms. And we were worried about this sensitivity to noise and problems in the data. We did a lot of simulation to show that InterVA was very sensitive to these things, and we wanted to develop something that was less sensitive. So by uncertainty here, what we're really talking about is that if we're unsure about the classification of a specific death, we want that to be reflected in the cause-specific mortality fractions at the population level as well. So I'm going to go through InSilicoVA in 2 ways. First, just talk through what we're doing, and then second, show a few of the equations that tie things together. So we start here by imagining a joint distribution of cause-specific mortality fraction vectors and the cause-specific probabilities for each death in our population. And then we're essentially going to do a Gibbs sampling approach. So we're going to repeat these steps many times until we have a sample from that imaginary joint distribution that we can then summarize and produce the distributions that we're interested in. So for each death, we're going to use the current cause-specific mortality fractions. We can start with anything reasonable. Together with the knowledge of the VA signs and symptoms, the SCI, the relationships between the symptoms and the causes, and the VA data themselves. And we're going to calculate a new probability for each cause for each death. So essentially, we're going to use everything we know, current CSMFs, the SCI. We're going to draw a cause for each specific death in the population. Then again, for each death, using those cause-specific probabilities, we're going to draw a cause from a multinomial. We're going to sum those up to create cause-specific death counts across the whole population, and then using those, draw a new set of CSMFs from a Dirichlet distribution. So we have two random steps here to produce some uncertainty for us. It goes back and forth between the individual and the population levels and produces for us a nice sample from that joint distribution. So here is the notation that we're going to use to talk about in silico. We have our J deaths Yj again. We have our causes. We have the data again being binary. And here we're going to use both the ones and the zeros. We have a J by N matrix of cause assignments for each death. So that's going to be capital Y. We have, again, the K signs and symptoms. We have here a vector like we did for inter VA of the signs and symptoms for specific death. Here we have something new. We have for individual J, the probability of cause N. So that's the individual probability for each cause for each death. And of course, we have a J by N matrix of those, capital L. Now we have a cause-specific death count, MN. We have the cause-specific mortality fractions, FN, and those cause-specific mortality fractions, of course, sum to 1. Okay. So the full InSilicoVA has a bunch more complication than what I'm about to talk about. Essentially, this is a heuristic to show you what's happening at the middle of the algorithm. There is a paper published in JASA where you can find all the details, and of course, you can talk to us if you want to. So those are the data like inter-VA. We have the cause-specific, we have the SCI, exactly the same as inter-VA. We took those. And here's a sketch of the algorithm. So we're interested in this joint distribution of the cause-specific mortality fraction vectors, and for all of the deaths, the probability of each cause. So that's why there's a matrix there. Both of those are unknown, and of course, this joint distribution is unknown, and it's what we want to estimate. So we introduce a data augmentation procedure and use simulated cause assignments to stitch these two things together. So we'll model the cause-specific mortality fractions conditional on the cause assignments for each death. And we'll do that with this Dirichlet draw. So we draw a set of CSMFs conditional on the current set of cause-specific mortality probabilities for each death from this Dirichlet. And the elements of N here are the cause-specific counts. And for those, we take the current cause assignments for each death, and we sum them up. So now we have a number of deaths in each cause category, and we can parameterize the Dirichlet like that and draw our new CSMFs. So this ties the cause-specific mortality fractions to the cause assignments at the individual level. The second step here is we're going to model the cause assignments, YJN, conditional on the cause-specific mortality fractions, and the data, the signs and symptoms coming from each death. So here we have the cause assignments conditional on the data coming from the verbal autopsy, and the current set of cause-specific mortality fractions in this simulation. And we model that as a multinomial draw parameterized with L, this big L vector. So that is a vector of cause-specific probabilities for each death Lj. So the individual cause-specific probabilities are the probability of that death being that cause, given our signs and symptoms for that death, and the population level CSMFs. So we can use Bayes' rule and write that like this. And then if we assume that the signs and symptoms are independent given cause, and therefore independent of F, we can remove that, and we have the individual cause-specific probabilities for each death being proportional to the probability of the signs and symptoms given the cause times the probability of the signs and symptoms given the current CSMFs. Now we can derive an expression here for the probability of signs and symptoms given a cause, just like we did with InterVA. So the proper Bayes definition is at the middle here of InSilicoVA. So that's as we saw before. And then we can put this back into the last equation on the previous slide, and the individual cause-specific probabilities for each death are now proportional to the cause-specific mortality fraction for that cause times this expression for the conditional probability of the symptoms given particular cause. So the symptom cause information comes in here with these conditional probabilities of each symptom given each cause. The data are here in the exponents, and this ties the individual cause assignments back to the population level CSMFs. So for computation, we take a sample from the joint distribution using a Gibbs sampler. This model defines the conditional distributions we need. We initialize the CSMF vector to something reasonable. It doesn't matter if we let it go long enough. And then we just execute those two steps many times until we get a stationary distribution. And then we summarize that distribution to produce what we really want. And those margins produce distributions for the elements of the cause-specific mortality fraction vector. So those are our cause-specific mortality distributions at the population level. And then for each death, we summarize and get estimates of this little Lj vector. So one distribution for each cause for each death, which is, by definition, consistent with the population level. Okay, so a quick summary of where we think InSilicoVA is strong and weak. So it provides a mutually consistent estimate of individual level probabilities of dying and population level CSMFs. Both are reported as distributions, so we have uncertainty for all of those quantities. It builds on InterVA and uses the same symptom cause information so that it's immediately usable. We didn't have to go derive new SCI to make this algorithm work. It provides information on all causes for all deaths, no indeterminate category here, and of course no threshold for determining indeterminacy. Uses information from all deaths to strengthen the cause assignment for each death. So because we're going back and forth between the individual and the population level, all of the deaths are informing the population level, which is informing each of the individual deaths as well. So we have a kind of strengthening and much more comprehensive use of all of the information in this algorithm. Compared to InterVA, it's far more robust to noise in the data. And we tested this with lots of simulations where we purposely do something to the data to cause it to have errors, and then we test. And it's computationally feasible. It's much more computationally intense compared to InterVA because we're doing all of that Bayesian-esque sampling. But it's still something that we can run in a few minutes on a laptop, so it works. And the paper is here. We published it in 2016 in JASA, and my colleagues Tyler and Richard there folks who helped us with the data, and I led the work. So a few observations on this work. We replicated work on InterVA and Tariff in order to do the preliminary understanding of what was happening and then develop InSilicoVA to address the issues. We discovered something. Replication is extremely hard. Most people, when they publish work like this, do not include enough details to actually replicate what they do. So we had a team at IHME that produced the Tariff algorithm, which I haven't talked about yet. Their publications are completely inadequate in terms of providing all of the details, and they are also completely unwilling to provide them when you talk to them. So we replicated and reverse engineered their software, and then they threatened to sue us. So this is very difficult. If you're trying to do things in the real world, things start to become extremely unpleasant. And then at the end, they said they would let us see their code because our reverse engineered code did not produce exactly the same results. They were annoyed about it. And they told us that we can have one look at their code if we pay them $100,000. So we said no, and we moved on. InterVA was very much the same. It was provided as a compiled Windows application. The publications are completely opaque. All of that derivation that I just showed you for InterVA doesn't exist in any of their publications. We also reverse engineered their code, Peter Bias's code. He was also very annoyed at us. We found lots of bugs. He refused to fix the bugs until we threatened to publish a paper where we revealed all the bugs. So we wrote several papers that didn't get published just to force other people to tell us what they were actually doing. And I think most of our academic projects don't go this deep because most of them don't have an application or an immediate application where people really care about it. Our situation is that the Bloomberg Philanthropies is trying to move this method into many countries right now. In fact, they already did it 2 years ago. So they needed something immediate and they needed people to be able to trust it. And with these things that were just compiled code, you don't know what's going on. So that's just part of what happened. So both of them also included lots and lots of pre-processing steps in the software that were not described in the publications. And in order to understand how the results actually arrived, you have to understand these pre-processing steps as well. So we are conducting ourselves in the opposite way, completely opposite. We're calling ourselves the OpenVA team. All of our things are open source. They're on GitHub. You can read every single line. And in our publications, we provide replication codes so that it's all open. So we are working on a bunch of new approaches that are addressing some of the weaknesses with InSilicoVA, but none of them are quite ready yet. So I want to show you one validation study here that we've done. We worked with the South African Medical Research Council. They did a very large VA validation fieldwork study. They did fieldwork between 2017 and 2019. They used the WHO standard verbal autopsy, had about 5,500 respondents. They did multiple physician coding, so they had multiple physicians read each VA. They used a piece of software called IRIS, which is an internationally used software for identifying the underlying cause of death, to recode and identify the underlying cause. And this population, because it's in South Africa, has a very large number of deaths from HIV. And not part of this story, but part of our work is that we started everything here in order to identify HIV deaths with VA. So it was important to us. So we worked with that team. We applied the InterVA5 algorithm, InSilicoVA, and the Tariff 2.0 algorithm from IHME. We compared the causes assigned by all of these algorithms. We calculated very many comparison metrics, and we published a paper at the end of last year. I'm not going to show you all of the results. This is just one part of one table. We have the three algorithms, and then we tested them on different populations. The total sample, we looked at neonates, children, and various categories of adult. And then we calculated individual level agreement metrics and population level agreement metrics. I'm going to skip over all of them and summarize them in this table here. So what I did was for InSilicoVA, calculated the number of times that it came first, second, or third in all of those comparisons we did for all of the different subgroups. And InSilicoVA was best 40 times, second best 13, and third 1. So in general, InSilicoVA does a better job. But if you look carefully at all of those results, what you see is that all of the algorithms at best are performing at around 60 to 65% accuracy. And even though InSilicoVA beats all of them most of the time, it's not by a huge margin. It's just a little bit better. And it's a little bit more consistent. So there's still a lot of work to do to improve this overall approach. The paper for that one is published here. I have a little bit of time, and I'm going to just talk quickly about a couple things. This is all of the software that we produce. It's all on CRAN for the R statistical programming environment. We have Python code for a number of things. And we have a publication here, the OpenVA Toolkit for Verbal Autopsies, which from a user's point of view goes through how to use all of the software. And I just wanted to say that we had an independent validation recently. The Ministry of Health of Tanzania did a study of their own of all of the algorithms and decided to endorse InSilicoVA and OpenVA for verbal autopsy. Here's that OpenVA Toolkit publication. So beyond InSilicoVA, we have a few limitations. This assumption of conditional independence is obviously a big deal. We lose a lot of information by assuming that symptoms are independent given cause, and it's not realistic because, of course, if you die from a given cause, there's a consistent pattern of symptoms that exists. So we can probably improve performance a lot if we are able to undo that assumption. And we have two approaches that are doing that now, and they do improve performance by 10 to 15%, but they're computationally extremely intense. They take 2 or 3 weeks to do what InSilicoVA is doing in 10 minutes. So we're working on making something simpler so that it's feasible. Here's a very big potential improvement. We don't use data from the free text account of the verbal autopsy. So there's a portion of the interview which just allows the respondent to describe what happened in their own words. This contains a lot of information, and the physicians use this information predominantly when they make their assignments. So we are embarking on a number of ways of doing this, and Clarissa here is leading part of this work. And then this is a big issue. We want at the global level to be able to compare causes assigned by verbal autopsy. And at the local level, we want the verbal autopsy to be as accurate as possible. And those two things are in conflict with each other. Because essentially for the global comparability, we need a algorithm, logic, and an SCI that's the same across all settings. But the epidemiology of each setting is a little bit different. In Africa, we have HIV and things like that. Here in Latin America, we have other things. We have chikungunya and a few other causes that predominantly affect populations here. So we want to adjust the SCI in Brazil, for instance, for those things, and in Africa for the other things. But then we want to bring them together at the end and compare them. So we have this, we want to develop a domain adaptive algorithm, and that's what we're working on now. And then I want to talk a little bit, and I'm going to skip here because we're running short on time, about the symptom cause information. But essentially, we have two ways of producing the symptom cause information. We can just go ask experts directly. We can get physicians and ask them for that conditional probability. Or we can compile a data set of reference deaths that have each record containing a verbal autopsy and a cause assignment from a trustable mechanism that's not an algorithm. And we're working on both of these right now. So I'm going to skip this a little bit. Here's the prob-based update. So we have a project now supported by Bloomberg with 65 physicians all over the world. We've got physicians in Latin America, we have physicians in Africa and Asia and Europe and the United States. And we're going to do a virtual elicitation where we have all of them look at all of the pairs of cause and symptom and give us their best assessment of the conditional probabilities. So that's a simple thing to say and a very difficult thing to do. We have a very complicated project to try and make this work well and do it in a statistically principled way where we identify rate of reliability issues and correct for all of those as we do it. So the second thing we're doing is the reference death archive. So we have this idea of developing a database that we position at the WHO in Geneva so that it's globally available. And into that database, we put high quality deaths with both verbal autopsy using the standard WHO verbal autopsy and a reference cause identified through a high quality mechanism that doesn't involve an algorithm. So right here is where the USP collaboration happens. I think about 2/3 of these deaths over the next 2 to 5 years are going to come from the SVO at the medical school, with folks in this room and Burns collaborating closely with us. So the other deaths are coming from a couple Gates Foundation funded projects. One is called CHAMPS, which looks just at children in, I think they have 20 sites all over the world. And another one is called COMSA, which looks at adults, and they have 2 sites in Africa, one in Sierra Leone and one in Mozambique. So we have those, the Gates-funded projects, we have the SVO here in Sao Paulo, and then we have a bunch of small research projects which will also produce deaths that go into the archive. And then finally, Clarissa and a few of her collaborators and me are beginning to work on how to improve the verbal autopsy algorithm, interview, to improve the quality of the narrative so that we can use NLP and other automated machine learning type approaches to transcribe the narrative and then do direct classification using the narrative itself, and then combine it with the algorithmic results so that we have both the narrative and the closed form questions contributing to the classification. So there is a lot of work. I'll skip those slides. I'll show you the people who are involved here. We have this team of folks. Here's Clarissa sitting here with us today. Zhenku Wu is a statistician. Peter Choi is a demographer who's left our project. Melina was a programmer who left the project. Here's Tyler and Richard. Jason Thomas is essentially a very good programmer in all languages, so he does all of the maintenance of our code. And then everyone else here works on some mixture of the algorithm or the data. Our 2 African colleagues are involved in a whole bunch of projects collecting data and will be integral to our reference death archive. And I haven't put anybody from the Brazil team because we just finished making a contract and making it official last week. But I'm hoping some Brazilian colleagues will join us as part of this team. If you want to look at the slides, you can go to that URL. And if you want to contact me, there's my email address. And I'll stop.
Thank you again.
Yep.
Perguntas? Querem fazer alguma pergunta? Não?
What's typically the size of the data set?
Yeah, they vary from a few hundred deaths to some thousands. Some of the bigger ones are 5,000 to 10,000. But what's happening now, because of this Bloomberg project that's trying to increase it at national scale, We are very confident that in the near future we can have data sets with 50,000, maybe 100,000 in the next several years. It's definitely going to happen because they're doing it. So they're collecting the data before we have any tools ready for them. It's unfortunate. Yeah. It's also why we're trying to move as fast as possible.
Ok, mas alguém gostaria de fazer alguma pergunta? Não? Então tá bom. Thank you very much
Thank you.
again.
Yeah.
We have our talk.
Okay. Oh yeah, let me take this off.
Okay.